Hi everyone, and welcome to this new episode of CardioBuzz. And today we'll be discussing a drastic situation, which is CPR. And we're not going through the basics of CPR, the compression rate, speed, the breath to compression ratio, the medications that we give. But we will go into the tricky situations of CPR from the cardiologist perspective. When to stop resuscitation, when to use mechanical circulatory support, when to go to the cath lab, when to use the mechanical compression, and other relevant questions. And I'm glad that we have our guest speaker today, Dr. Naeem Toosy. Dr. Naeem is a consultant of emergency medicine, currently works with International SOS, and he's an adjunct assistant professor of clinical science at the University of Georgia. He started his career in the UK. After working as a consultant in the UK, he came to the UAE, where he was the head of the emergency medicine at Khalifa General Hospital, Al Quwain, and then he served as the clinical lead in Al Qasimi Hospital. He is a member of the Emirates Society of Emergency Medicine, the chair of the Arab Health Emergency Medicine Conference. He's a member of the World Health Organization. He's the founder of the Northern Emirate Emergency Club, and he was awarded as the Distinguished Specialist by Health Magazine in Dubai Health Authority. Welcome to CardioBuzz, Dr. Naeem.
Thank you, Dr. Hussain. It's very kind of you to invite me.
It's our honor and our pleasure.
Welcome to CardioBuzz, your one-stop shop for all things cardiology. We bring the latest news and research on heart health, summarize the latest guidelines, and interview experts in the field.
So when we do CPR for someone who had cardiac arrest, our focus is on the heart, whereas actually we are resuscitating the brain. Could you explain to the audience what does resuscitating the brain actually mean?
Definitely. I think I agree completely. Although we're trying to restart the heart, that's the focus. But the main objective during this attempt is to ensure that the brain has enough oxygenation to survive. The brain is a very sensitive organ with a very high oxygen demand. And it's the first organ to get damaged with lack of blood flow carrying oxygen. So definitely the main problem with resuscitation is the longer the attempt lasts, the less the brain is getting oxygen. And obviously what that means is the outcome is bad or not so good. So either the person, even if he survives, he has a very poor quality of life and functional outcome, or he doesn't survive at all. So just restarting the heart should not be the goal. It should be to make sure you restart the heart with a functioning individual.
And in order to achieve that, we need effective chest compressions.
Yeah, and this is a time-sensitive condition. The earlier chest compressions are started, the better it is. Every minute without effective chest compressions means there's less perfusion to the brain, less oxygen to the brain. So one of the most important elements is early recognition. That means in a pre-hospital situation, really you depend on the members of the public or family or friends or colleagues or bystanders to recognize something's happened, there's cardiac arrest, and then start chest compressions, but also then activate the emergency services. So this has to happen really quick in order to have a good outcome.
That's great. The big question is when to stop resuscitation effort, especially when you're facing a young gentleman who collapsed because of an acute myocardial infarction. He was previously healthy, leading a normal life. You feel sorry if you just simply declare him dead. So shall we continue resuscitating for 1 hour, 2 hours?
Yeah, it's a very, very good question. I'm sure people are really interested in that answer. It's really, really important then, while you're resuscitating, to figure out how quick was this person resuscitated, i.e., was there a witness to this arrest? And then how quickly did they start resuscitating? How quickly did some professional help arrive? Now, that is sometimes difficult to get information. And I suspect from my emergency medicine, by the time a patient arrives in emergency medicine, most people will tell you, oh yeah, we started something straight away. But in fact, if you really dig into it, you find that they spent quite a lot of time sort of calling friends, talking to other people. So it's there's a delay process. And what that really means is that outcome is already compromised, right? Now, the thing is that we know from data that the longer the resuscitation goes on, the less the chance of then good survival. So beyond 30 minutes, actually, you're really talking about diminishing chances of good survival. When you reach 45 minutes, then you're really, unless there's special circumstances, if it's a drug related, i.e. overdose, we continue for longer. If there's been an hypothermic episode, so somebody who's fallen in a cold lake, and then obviously you've got to warm them up, that takes a long time and you can continue. So there's special circumstances where you can continue for a lot longer. But in most circumstances, once you've gone beyond that and there isn't an obvious reversible cause, then it's a diminishing return. But I think what we're really talking about, when should we stop, is what I do, I'll talk about my own practice often, is start chest compression, CPR, figure out from bystander what's the actual story, then figure out what's the chance to survival, continue for a period and do everything you can, making sure you give really, really good CPR. But the thing is, once you've done everything, then you have to really think about it and make a good executive decision, a real decision for the patient and for everybody. Because continuing for on and on and on for a very long period of time essentially got the heart started after an hour and a half, for example, which takes a lot of resources from the emergency department. But that doesn't matter. But if you follow this patient up, you find he eventually gets to ICU, never wakes up, is in the ICU for 6 months, a year. If he recovers, he's really got a very poor response, is in basically comatose, or he dies. But after a year in ICU, which is a huge drain on resources. And if it's in the private sector, it means there's a huge amount of bill to be paid as well with no outcome. So this is something, unfortunately, we come across. So you have to really use some wisdom in your decision making.
Of course. Now, speaking of resources, if we engage in CPR and we continue for 45 minutes and we have limited manpower and everyone would try to escape from doing the chest compressions because it's the most exhaustive, especially for the lumbar spine. So what does technology offer in this regard?
Yeah, we've had access to for quite a few years. It's mechanical chest compression devices. One from Sweden called Lucas, which was developed by the Lund University. And we have several carnations of that. So we have developments in that device, a newer and better device, basically. And we also have others called like CorePulse, which is a German device. And then there's others which actually have like a belt, which cause contraction of the chest. So there's different devices. It hasn't been proven if anyone's much more superior than the other. There is very little data on that aspect. And there isn't really evidence to show that it's better than manual CPR, but we all use them. And the reason is for this exact reason that I think you've mentioned, that doing a prolonged CPR is very, very exhausting on the team. It's very resource heavy. So you need to have 2-3 people just doing chest compressions, alternating. And then what's worse is if you're trying to move the patient with the CPR, so particularly in ambulance, it's almost impossible to safely move with manual CPR because, you can imagine an ambulance moving, somebody's, the paramedic or somebody's trying to do chest compression while the ambulance is moving, braking, turning. That's not a safe situation. And it's not going to provide effective CPR for sure. So I think the mechanical devices have come in, and most ambulance services now are using mechanical devices once they transport the patient to an emergency department for sure. So it's a very big resource assistance, but I think the problem is that it hasn't really proven to be the golden nugget that's improved outcomes yet.
So let's try to find something that can improve the outcome. Now we're fascinated by the mechanical circulatory support.
Yes.
And I think the one that is most applicable for CPR would be the extracorporeal membrane oxygenation. So can you tell us your perspective on putting an ECMO device in the emergency in the situation of CPR?
Yes, this is something I've been really fascinated by over a period. And I've followed experts who are really doing this. I actually saw the people in San Diego do it effectively. I think in Minnesota is a big program. And then Paris does pre-hospital as well. It's definitely the way forward, because by getting this person on an artificial circulation, you can improve the circulation and the oxygenation of the brain much better. And then you can move this patient to the effective place. So if we think it's myocardial infarction related cardiac arrest, then to the cath lab, obviously. Or even if you have to do the CT scanner, if you're going to need to, or you can do echocardiograms, you can do lots of different things with the ECMO on, and it buys you a lot more time. If that is a disadvantage, it's not the magic bullet. So the idea is to get it on really quickly. You can't spend there 1 hour doing CPR and then say, okay, by the way, let's get an ECMO device now, because already the brain damage has happened. You're not going to reverse that. Ideally, what we want to do is resuscitate the person quickly with defibrillation and good CPR early on. So within 5 or 10 minutes, if you do effective or excellent CPR, you can bring people back, and then you move to the cath lab. But if the guy isn't improving and not getting better to a normal rhythm, then it's really important to get that ECMO on early. And most of the people who get it on very early. So I'm talking to a gentleman who runs a program in Paris, for example. It's a pre-hospital program. So they put the ECMO on at the scene of the patient. And in fact, they've got amazing pictures of them putting a person on ECMO in the Louvre Museum. And they can do it on underground. They can do it everywhere. So it's amazing. But the thing is, when I was talking to him, they say, we get activated immediately on finding a person in cardiac arrest. We start moving, and then they cancel us if they need to. So we're there within 10 or 15 minutes. And then we can put the person on ECMO. So our aim is really to put the ECMO on within, say, 30 minutes maximum of the person going into cardiac arrest. So that is very, very quick.
And what level of training and readiness and expertise is necessary to achieve this job?
Yeah.
Wait, fast response.
I've quizzed the experts a lot on this, and I think there's different views. It does need a lot of training in order to cannulate. You put large cannulas in the venous and arterial side, and you need to do that quickly. And then the machine isn't actually, now the development with technology, the machine is expensive, but it's not that big. So you can take it everywhere. But you need good expertise to put this thing and start it on. And you need a team. It's not just a matter of one person or whatever. I think different people have different takes on this. And in Minnesota, they have like a van or a truck that's set up like a cath lab, I guess. And they use what do you call it? An X-ray, to fluoroscopy, correct? Sorry, to ensure that the cannula is in the right vessels and which vessel they're in before they put larger cannulas in. But then in France, they do it pre-hospital. They can't do that, and they just do it based on ultrasound. For example, in the Paris team does 80 a year pre-hospital. So it is possible, but you need a high level of training. You need to have a very small, well-trained and on-call team who is constantly going to respond all over the city.
Do we have evidence that adding ECMO to CPR armamentarium would result in a significant improvement in the outcome?
I think the evidence is always challenging to come by in these situations because you're talking about a few selected patients who can get it in time. But they do have a lot of data, and these aren't type A evidence, so they're not from randomized trials and whatever. But what they say is that in people with certain rhythms, so if it's a VF-VT rhythm initially, which most often indicates, as you probably agree, a ischemic event rather than other pathology. Now, if that was the initial rhythm, then what they say is up to 30 to 40% neurological intact survival can be achieved. And then that's a huge gain because at the moment, currently, I think for most programs in the world over, it's less than 10% who actually survive. And not all of them survive in an excellent condition. So probably much less that. And this is for the VF-VT. But for this most common rhythm, I think they can achieve a decent outcome. In Minnesota, what really struck it home to me was they do a annual reunion of all the survivors and they bring them together and they have a picture. Not everybody comes, obviously, but of those who come, they have a picture all in a hole and all of them standing, laughing, joking with the team. And these are all people who were in cardiac arrest. So that really hits me home. To think, God, all of these guys could have been dead, but they've been saved by this excellent teamwork and the system, not just ECMO.
And that's the glory of medicine, saving lives.
Well, absolutely. And that's the pleasure of it.
So after decades of practice, Dr. Naeem, what do you think should be done at the national level, let's say, to reduce the cardiovascular mortality in patients with cardiac arrest? What could be done? What would the society and the community do?
I think that's a really excellent question, Dr. Zain, because I've sort of highlighted technology, and people may get the idea that it's all about getting the expensive technology and the very highly trained teams. But that's not really the answer in my view. That's only applicable in certain areas where you've already established the basic. Unfortunately, in our area, that the basics haven't been established yet. So the very, very basic thing is early recognition. People need to be trained to recognize. It's not that easy to recognize cardiac arrest initially. People think, maybe he just collapsed, maybe he's had a seizure. There's lots of things, and people may not realize. And until now, it depends on a very imprecise thing called pulse check. So you're checking somebody's pulse, and it's been proven that the pulse check is very imprecise. And that's for a doctor's hand. What about a layperson's hand? So we're already in a realm of difficulty right from the beginning. And I know from the people who run the programs for FIFA at stadium that they aim to have the team. If somebody collapses, a football player, for example, suddenly collapses, they aim to have the team on the side of the person, and defibrillate within 2 minutes, right? So that's the aim. Now, you can imagine in the community, within 2 minutes is a hell of a challenge. But you can achieve it, but you need to have a network of responders. So a very, very wide network of general public responders who are trained and supported. Now you can use policemen, you can use taxi drivers, you can use delivery drivers, you can use community, people who are everywhere in the community. They need to be supported. And then somehow, say I have a person who arrests, I should be able to, when I activate the emergency services, modern technology, in my view, can help pinpoint that and locate the person closest and direct him directly to that place. And they may have a defibrillator, or we can get a defibrillator to them. But that needs to happen within 4 or 5 minutes of the event. And the emergency service then is activated, show up, do more advanced things, medication and defibrillation. And at the same time, then if you can achieve that, then maybe have an ECMO program or something else for people who are not responding. So all of these are pieces of a puzzle that have to go together. It's not just a matter of having an ECMO program. In big cities with a very advanced level of health awareness, maybe just possible. But if you're talking about countrywide, worldwide, it's going to be a challenge. So that education for me is key, and maybe should be starting, in my view, in schools. So CPR training should really be part of the curriculum. And it's not in most places. I think in the UAE, I just want to say, we've made a big step forward, because there was a worry among the general public that if somebody collapses, if I touch him, will I be blamed? Will the police arrest me? And I think now with the work of ECM, particularly ECM founder, Dr. Saleh Faris, there's a Good Samaritan law that's been passed, which protects the public if they respond. But that needs to be, the public doesn't know that yet. Not everybody knows that. And so it's really important that that's disseminated.
So let's stress on this point. So we now, in the law, we have the Good Samaritan rule.
Yes.
So if someone witnesses a collapse and he thinks that it's cardiac arrest and he starts resuscitating, he's not going to be blamed. He's not going to be accountable. He's not going to be taken to the court of law.
That's correct. I mean, there's the law, it protects individuals. And I think UAE is one of the first countries in the GCC, at least I know, that has that law enshrined in law.
That's great.
So that's a good step. But that's a good first step. That's the protection. But then you need to make sure that information is disseminated to everybody, and then people are responding and able to perform CPR effectively as well. So I think there's lots of challenges we need to overcome. But then, so the next step might be technology, in the sense of what we were talking about, the very high level technology.
So it starts by recognition, training of the public on CPR, building and organizing the network where the healthcare system is able to reach and start CPR, and then going into the advanced technology of CPR.
Absolutely. I looked at the data, and in the USA, 400,000 cardiac arrests pre-hospital, right? 90% don't survive. That's 360,000 people, right? Don't survive. And if you can increase, I did a quick calculation, if you can increase that 10% to 30%, you're saving 90,000 lives, right? And total people who die from road traffic collisions in the US is 40,000. So you can double the amount of survivors from just by increasing survival a few percent, like 10 to 30%, not even 100%. So it's a worthwhile endeavor to have that system and work on it, in my view. And I think we really, it's our duty to make sure that we can establish a system that can deliver that for the public. We owe it.
We spread the awareness, and we've taken the steps. I mean, the government has taken the steps. So let's be optimistic for the future.
Indeed. I hope so.
Thank you so much, Dr. Ray. It was a pleasure having you. And I encourage the audience to send us questions and to share the episode and post their comments. And I hope that we meet you again in future episodes.
Thank you for
so
inviting me and giving me the opportunity. Thanks.